Okay, so let me start with a very, very bold statement. There is no consensus on the best intra-procedural parameter to evaluate residual mitral regurgitation after TEER. All of us entirely depend upon our visual impressions, which are by far probably the best. But unfortunately, what happens is that for a novice who is already there, who knows nothing about it and is just about to start, they need some objective parameters to say what is the quantum of residual MR. Now, not to get into the co-opt versus mitra FR controversy, this procedure and technique is here to stay. And when it comes to assessing mitral valve pre-op, there are very standard ways to do it. The very standard ways to do it, we know that there are standardized mitral regurgitation quantifiable parameters that we can trust. There are certain things which are very apparent and evident because most of the times we are taking very significant MRs. Where we are not getting into that controversy whether it is mild or moderate or severe, they are indeed significant MRs which are being taken up. Problem comes when it is post-operative or post-procedural issues that you have to calculate. Now these are certain pre-op images which are there, and once you are through with the procedure, the thing doesn't seem to go like the way I wish. Anyway, so this is gross MR. As you can see, there is no problem in assessing it. Whether you calculate the area, whether you calculate the left atrial area versus the regurgitant jet area, whether you want to calculate the vena contracta, spontaneous PISA, name the thing and it is there, and whether you want to do the pulmonary veins assessment. There are certain things which have come in very handy. Unfortunately, post-device placement, the 3D also doesn't work too well because you are not really. So these are certain things where we know how to evaluate our preoperative MR, and moderate to severe SEER are the ones which are there. This is the leaflets which are there, which are to be grasped, and once you see it happen, you're sure that you have done a good job. Most of the times, people will think that they have done a good job. Again, if this were to be the plane of evaluation, the top ones are pre-op and the bottom ones are post procedure. And if you look at this, you are happy. You're really happy. But unfortunately, we have not quantified it, that what is the issue. Now, this is something which is a transthoracic image post-TEER. You know you have helped the person well. The device is well in place. When you look at the color, you know that there is hardly any color flow, and you are very happy with that. During the procedure, you have taken the pulmonary venous flows. There is no systolic decapitation or reversal of the pulmonary veins in systole. These are certain things which are very good. You can go ahead and check on paravalvular leaks. Not only this, you can check on other mitral valve pathologies, not necessarily TEER, but here if you look at it, these are good jobs when people have done this. This is something which I just wanted to add on, that paravalvular leaks can be also plugged very well. And again, if you are satisfied it is nothing significant, the problem comes when you are not satisfied with this. Now look at this. Are you happy that this is a mitral leaflet, mitral regurgitation which is non-significant? I will not be very sure. Unfortunately, you can't rely on the chamber dimensions. Pre-operatively, if there is a mitral regurgitation, you start suspecting significant mitral regurgitation the moment you start seeing the left atrial and the left ventricle dilated. Post-TEER, this parameter goes for a 6 because it's too quick for the LA and the LV to regress, if at all they do. But we know that when you do a transthoracic echo, you are not looking at something very great. The earlier picture was of the same, this patient. And when you look at this, you know that this wobbly thing is something which is worrisome. So we are not too sure what it is. Now, what the world has tried till now is the role of 3D VCA Unfortunately, in this respect, only about 28% patients could. This is, have I gone back? So this is only 28% of the patients could be included due to lack of availability of adequate 3D data set. This is a major limitation with 3D. People have used quantification with pulmonary venous flows. Unfortunately, it is difficult. Many times you will get pulmonary veins. If you get them, you're good. If you don't get them, you are again struggling. People have tried to calculate the similar results have been found with systolic and diastolic ratios. Unfortunately, nothing has come out well. These are the ones which are worrisome. Unfortunately, this looks mild, if at all, moderate or severe, don't know. But these are the ones which is the matter of concern. So after all, why is there such a big issue? Because we know that when we start looking at regurgitations of the same patient, we are probably underestimating the mitral regurgitation. So what have people tried and tested is something very different, and I'll just come to the sum and substance of it. The sum and substance of it is that maximum vena contracta cutoff point of 0.45 centimeter has demonstrated 88% sensitivity and 89% specificity to predict persistence of MR, which is more than grade 3. This is one single parameter which has till now, I'm not saying don't do anything, you must do everything. It has to, because we are still looking at 12% lack of sensitivity and 11% lack of specificity. So you have to have that goal in your mind. And of course, this is when it happens, you are then lesser struggling. If you have to go for one objective parameter, then it is the vena contracta which works well. This is what the paper was published in May 2022, correlation of intra-procedural and follow-up parameters of mitral regurgitation grading after percutaneous edge-to-edge repair. And this is what they concluded out of it. When intra-procedural quantitative parameters to assess residual MR after TEER were individually evaluated, and they evaluated just about everything, only maximum and additive VC vena contracta were associated with persistence of significant insufficiency. As the former variable showed the best performance, measurement of maximum vena contracta may constitute a good single estimation of significant MR right after device implantation. So this is where it is. The problems are when you have more than one jets, so you have to have it consolidated. Chronic MR leading to a large LA. Interference of clip for exact evaluation, need to be innovative, and you have to get the best imaging planes. You have to be good at unconventional echocardiographic views to get the same things. Thank you very much for a patient listening.